A fetal ultrasound provides a real-time observation of pressure gradients and fluid dynamics. We are watching a live mechanical system in motion. Medical training frequently reduces complex developmental pathologies into a series of simplified visual buzzwords. Students are taught to scan for the banana sign, the lemon sign, or the double bubble. Relying on rote memorization of these specific shapes fails immediately when an anomaly presents in a non-standard variation. The developing fetus is a closed mechanical system. Every structure within it is strictly governed by the laws of physics. Every abnormal sonographic signature can be reverse-engineered back to a primary event, a structural obstruction, a pressure failure, or a boundary rupture. By tracking the biomechanical origin of an anomaly, a seemingly random distortion on a monitor becomes a highly predictive clinical narrative. The structural deformities of the Chiari 2 malformation begin with a single physical defect, an open neural tube, specifically a myelomeningocele located in the lower spine. A precise volume and pressure of cerebrospinal fluid, or CSF, must be maintained to properly distend the fetal ventricular system. This animated diagram of a fetal neuroaxis illustrates the problem. The spinal defect operates like a valve stuck open, acting as a continuous leak that causes a systemic drop in CSF pressure within the cranium. Without adequate fluid distension, the hindbrain loses its structural support. Gravity and negative pressure pull the cerebellar structures and the brainstem caudally. This creates a physical bottleneck. The cerebellar vermis and the fourth ventricle herniate directly into the narrow opening of the foramen magnum, obliterating the normal round contour of the vermis as it stretches to fit the space. This tightly curved, distorted shape is the classic banana sign. Because it is a direct mechanical result of the spinal leak, it maintains high diagnostic sensitivity and specificity throughout the second and third trimesters. That same internal CSF pressure is doing necessary work at the front of the skull. It pushes outward, providing the resistive force needed to shape the developing cranial bones. Looking at this axial view of a developing fetal skull, we see the effects of that systemic low pressure. The outward force drops, preventing the rostral skull from fully stretching. The frontal bones buckle slightly inward under the lack of internal support. This inward scalloping creates the distinct contour known as the lemon sign. The diagnostic utility of the lemon sign comes with a strict temporal constraint. It is only visible during the second trimester. As the fetus enters the third trimester, the sheer mass of the growing brain tissue physically expands. This solid tissue forces the collapsed frontal bones outward until the skull achieves a normal curve, completely overriding the lack of fluid pressure. The lemon and banana signs are predictable topographical deformations caused by a single volumetric leak in the lower spine. A healthy fetus develops entirely enclosed within the smooth, protective boundary of the amniotic cavity. Sitting directly outside this amniotic membrane is the chorionic cavity. The pathology of amniotic band syndrome begins with a mechanical failure, the disruption or tearing of the protective amnion. The exposed chorionic cavity is a hostile environment, heavily populated with thick, sticky fibrous septa. If fetal limbs or head structures drift through the tear and into the chorionic space, they immediately risk entanglement in these exposed fibers. Once a limb is caught, the fibrous bands act like a tourniquet.
They constrict blood flow, causing severe vascular compromise that eventually leads to the mechanical amputation of digits or entire limbs.
On imaging, this presents as amputated features alongside a completely normal skeletal survey. In some cases, the entangling bands themselves can be visualized directly on the ultrasound. The amputated limb is a localized environmental injury caused by boundary failure. It occurs entirely independent of the fetus's intrinsic developmental programming. Fetal hydrops is a catastrophic state of systemic fluid overload. The mechanistic triggers for this state are divided into two categories: immune causes, primarily from Rh sensitization in a prior pregnancy, and non-immune causes, including severe viral infections or alpha thalassemia. This cross-section of a fetal torso illustrates the strict diagnostic criteria for hydrops. The diagnosis requires the physical presence of 2 or more abnormal fluid collections in the body. We look for specific zones of pooling, pleural effusions compressing the lungs, pericardial effusions around the heart, ascites in the abdomen, or massive subcutaneous edema. A critical, frequently missed sonographic indicator of this fluid overload is a thickened placenta measuring greater than 4 to 5 centimeters. Physicians anticipate this failure by measuring the middle cerebral artery, or MCA, using Doppler ultrasound. The hemodynamic logic here is straightforward. As the fetus struggles to oxygenate, it forces an increase in peak systolic flow to the brain. This compensatory mechanism predictably occurs right before gross hydrops physically manifests. Hydrops is the final, visible stage of total physiological exhaustion. The fetus can simply no longer maintain its osmotic and cardiovascular balance. Topographical obstructions within the internal organs produce their own distant cascades. The classic double bubble sign seen on an antenatal ultrasound or MRI is a prime example. The mechanism is duodenal atresia. A physical blockage in the GI tract causes backed-up fluid to dilate both the stomach and the proximal duodenum simultaneously. Moving upward to the chest cavity, we find congenital diaphragmatic hernia, or CDH. In CDH, a defect in the diaphragm allows abdominal contents to push upward into the chest. In 85% of cases, this occurs on the left side. The herniated organs create a massive space-occupying lesion in the chest. This physical crowding prevents the lungs from expanding and developing, causing severe pulmonary hypoplasia. Because the intestines are developing inside the wrong anatomical cavity, the normal process of gut rotation is physically impossible. This results in malrotation in every affected child. A simple defect in the diaphragm initiates a mechanical cascade that destroys the functional potential of both the respiratory and digestive systems. Once the mechanics of an anomaly are identified, the physician evaluates the resulting data to stratify the risk for underlying chromosomal aneuploidy. Ultrasound markers are organized on a strict hierarchy of diagnostic specificity. This pyramid maps the hierarchy. At the high specificity peak, atrioventricular canal defects and duodenal atresia, linked to trisomy 21. Cystic hygromas also occupy this tier, correlating with Turner and Down syndrome. The wide base holds low specificity markers, echogenic bowel, short femur, and choroid plexus cysts. These low specificity findings are frequently normal variants when seen in isolation. They can also result from non-chromosomal issues like localized ischemia or cystic fibrosis. However, compounding data heavily alters the probability. A single echogenic focus in the cardiac ventricle multiplies the baseline risk of Down syndrome by 4. Diagnostic mastery in fetal ultrasound requires synthesizing these isolated visual anomalies into a unified understanding of physical constraints, fluid dynamics, and genetic risk.